Dr. Middleton, and I'm going to be here talking to you all just a little bit, kind of piggybacking on a lot of the things that Nichelle said regarding your conference. And we're talking about breaking down barriers and building bridges, which is necessarily a guide to address the mental health needs of youth facing neurodivergent challenges. Just to give you a little bit of background about myself, I am a licensed professional counselor in Ohio. I've been doing this for over 15 years. So I've worked with youth, I've worked with adults with various mental health concerns, as well as with some chemical dependency issues as well. I mainly see adults, but I have seen some children and youth that are diagnosed with neurodivergent concerns, and also those that have been misdiagnosed, which I'll get into a little bit more. Currently, I'm a counselor educator at The Ohio State University as an assistant professor, and I coordinate our clinical mental health program there as well. My research is grounded in African American and Blacks in higher education and healthcare, creating equity and access, and gifted and talented education, as well as some addiction, counselor supervision and training, and then social justice and advocacy, as well as things related to clinical mental health and supervision. I do have some service work too, where I've been past president of a couple of the Ohio chapters of Ohio Counselors for Social Justice, and also the Substance Use Disorder Professional Committee. And then with Ohio State, working with our undergrad curriculum and really supporting those efforts to launch an addictions track at our school. So enough about me, more about what we'll be talking about today. And I'm wearing my glasses, y'all, because I cannot see. So I hope it's not creating too much of a glare. You can't see my face, but I am here, but I'm kind of squinting a little bit on that. So bear with me. So I do have a quick outline. What we'll be talking about, I'll give you some background into mental health. I'm not going to go too deep into it. I'm assuming everybody here is professional or versed into mental health, but I'm going to give it to you from a different scope. We'll also be talking about some challenging issues that come up when you're dealing with the neurodivergent population. And finally, bridging that gap and coming together and really conspiring with one another in order to provide, equitable and appropriate care for that population. So anytime that I sit with a client or I sit with students and we talk about mental health, one of the things that I really, really want to talk about and dig into is what exactly is mental health? Yeah, we know the textbook diagnosis of it. We know the textbook definition. But when we think about mental health, where does that come from? What is the origin of mental health? It doesn't just come from anywhere, where for some people it does, but we got to really think about what is going on within our mind. What is it going on emotionally? What is going on physically and within our environment that could perhaps be triggering some of these mental health symptoms that people suffer from? And what I have to think about is our basic human need. Okay, our basic human need. Many times when clients come into my office or I'm talking with students or I'm teaching, there's always something that is lacking within their space. So for example, they may say, well, I don't have positive relationships in my life right now. Or I'm struggling with getting secure employment, or it could be a situation where people aren't relating to me or I'm not able to relate to people in a lot of different areas of my life. For some, there's fear of safety. Maybe they're in some relationships that are a little bit volatile, or maybe there's some family dysfunction or things that are going on within their space where they're not feeling loved, they're not feeling safe, which can in turn impact their self-esteem and then their ability to prosper, or as you will, self-actualize and really live up to full versions of themselves. So we have to consider when our socio-emotional needs are not met, how are we responding within those spaces? And I always like to think about it as a child that's crying in the crib, right? And I've got two kids. They're teens now. Well, kind of grown, I guess. But when they're crying, they want a bottle. They want to be held. They want to be nurtured. And so their only response that they know is that I have to cry or I have to cry out to get that type of support. And so when I think of that crying out, that is how our body is responding when some of these basic human needs are not being met. That's where some of the anxiety, the depression, the different things that people deal with. A lot of times what filters into that are, substance use concerns and other things that, environmentally are triggering within our space. And there are some genetic components to mental health as well. Like if there's a history of family concerns within that space, then that's something to think about too. But for the main part, just thinking about Maslow's hierarchy of needs and what happens when these basic quote unquote needs are not being met. How am I responding? How are people responding within that space? And something that's very key As we think about our minoritized populations, I'm talking about our race, ethnicity, our gender, we got to think about that multi-generational trauma and how our body responds. If you grew up in a home that was filtered with substance abuse or even physical or verbal abuse, and you saw your mom or your parents going through that, and in turn, how does that impact how you function and how you relate to the world? So these are definitely things that we will have to think about and consider, as we're moving forward with that space. So your textbook definition will tell you when it comes to any type of mental health disorder, right? There are some significant disturbances in thinking, feeling, or behavior. So significant means that people outside of us may be able to see that something isn't quite right, or we're not functioning to the highest version of ourselves. And this can be demonstrated in a lot of different ways, which I'll get into, but there is significant distress in our functioning. We may not be able to get out of bed in the morning to go to work, or maybe when we do show up, we're not able to really perform in the manners that we're used to. We're not functioning in relationships, so we're not as present. We're not as cognizant of the different things that we normally would be cognizant of. Maybe we don't know how to respond to different situations. What we really look at as clinicians is, what is that deviation from normal functioning? What is that thing that's happening, and what is that space what is going on within us, those signs and symptoms, and then that frequency and duration and that severity of those symptoms too. What is going on within that person, and that's different than how they were functioning? And that is usually when people come into counseling or they come into any type of professional help, is something has changed for me. Something has changed for me. I'm not sure exactly what it is. Something has changed, and this needs to be addressed. And so therefore, I'm seeking professional help, or I'm seeking some type of support. Usually it's that base, it's something deviating from that baseline functioning. Now in kids, this may look a little bit different, okay? And I put some common diagnoses up here for youth that we'll typically run across. But a lot of times the symptoms that we see in children are they're withdrawn. They're not as focused. There may be some defiance or maybe some opposition to certain things, okay? Because they can't really truly articulate how they're feeling, what's going on, and essentially how to describe in words that I just don't feel like myself. And so what happens is we run across that opposition, we run across those things, we run across, those spaces where children just cannot essentially communicate, hey, that something is different with me. Something is different, something is unknown, and I don't know how to communicate that. So I may lash out in anger. I may lash out in frustration, and I'm not quite sure what is going on. And so when I work with children, unfortunately, one of the main diagnoses that I see is oppositional defiant disorder. And that can get a whole keynote on its own. But that diagnosis itself is patterns of anger, irritability, defiance, and vindictiveness, as it's phrased through the DSM, which we use to diagnose, but speaking more so to adults. So a child who may not listen to directions, or a child who may have difficulty, following rules or norms or something, so to speak, immediately they're slapped with this ODD diagnosis, which can definitely carry them throughout their childhood and into adulthood and beyond. There's also some ADHD that we'll see. And then what I really want to look at is like some post-traumatic stress disorder. There's some specific learning and then social communication. And this is not an exhaustive list. But what it is, it just gives you a baseline of these are some of the things that we see when we are working with children, when we're diagnosing them. And, in my training, I'll be honest with you all, when I was coming in, autism spectrum disorder was not in the book when I learned how to do the work that we're doing. And I've been doing this for over 15 years. So when I was first trained, we had Asperger's, and then I think we did have autism, but there was no spectrum. And so a lot of these behaviors, a lot of these thought patterns, and a lot of these, things that deviated from the quote unquote norm were usually thrust into one of these other categories. And then the R word that we don't use anymore was also being used as well. So a lot of children were getting misdiagnosed or underdiagnosed or overdiagnosed because we could not really truly capture what were those symptoms and what were those things that were going on with them that made them different from the norm. And so a lot of times it was deficit-based thinking that led to them being labeled essentially for being different and unique within their spaces. And so that's something that we really got to think about there is how I get a lot of adults in my office now that'll tell me, well, I got diagnosed with autism as an adult. or I got diagnosed in this manner later in life, but it was not caught earlier. And so they went through school, they went through environments, they went through spaces where they were not necessarily being, addressed in those spaces. And so now, as I'm teaching and I'm learning and I'm doing my own work, what we have is our term with the neurodiversity, which is, again, brought us all here today, and we're here to have these conversations. But this is a recognition of neurological differences. And again, I would see children, or I would see adults even in my office, that had some of the classic quote-unquote diagnostic criterion, but because we didn't quite know as clinicians where to fit it, the misdiagnosing happened. And if you have a child that has reduced eye contact, I've had some clinicians say, oh, well, they're being defiant. They're being defiant. They don't want to listen. They don't want to follow norms. Lack of facial expressions. Oh, that person. I've even heard as far as to say they're sociopaths or psychopaths because they can't really express emotion. Body language is different. If there's repeating gestures or repeating sounds, again, the R word we don't talk about anymore, was definitely in play during those spaces. And if there's focus interest, sometimes that got pushed off into ADHD. If there was, again, indifference to extremes, some of those disruptive disorders were being used too. And that is one of the biggest concerns and biggest misconceptions when we deal with people that are suffering from both or comorbid issues is, how do you define it? And what does it look like? And if we don't know, we're just going to throw it into a catch-all and we can figure it out along the way. But that figuring it out, how does that impact that person? How does that impact their space? How does that impact their family, their community? How as clinicians can we work together to truly work and identify, some of these concerns that people are having and put them on the path towards success. And this is just the basics of what I'm giving y'all. Something else that we really got to think about is some of these other factors that come into play. In schools, right? Many of our children are exposed to violence, whether it's in the community, whether it's in the home, whether it's interpersonal, where they are in fact being victimized to a degree. That violence is crucial. There's some gender and sexuality and identity concerns that are happening. Again, when I was coming up in school, we didn't really have much of this. A lot of it was not really even talked about. The biggest issue we might have had was bullying. But that's been even exacerbated when you have someone that's on the spectrum, or you have someone that is identifying or diagnosed as being neurodivergent, because they're different, because they're unique. So what do we do when they're not unique, or they're straying from the dominant, so-called normalcy? They get bullied, they get picked on, they get teased. Children also deal with death of a loved one, death of teachers, death of family, friends. Now we're seeing a lot of the violence or suicidal rates are high. So death is something too that's going on. Again, domestic and partner violence, racialized or ethnic trauma. A lot of children are being faced and lamented with racial microaggressions and racist incidents and things such as that, which are definitely detrimental to their psyche and their ability to function. And this is including some of the other things we've already talked about. So we're just doing layers right now. Physical and emotional and sexual abuse. What about this housing and food instability, which I talk about a little bit too, some financial concerns. I was always ready to stay in the child's place, but that didn't mean that I didn't hear adult things and that I was not being exposed to adult things that were going on within my space. There's also mental illness and substance abuse, generational trauma, natural or human-made disasters. Katrina from a couple years ago, and then the floodings that are going on in Texas. Some forced displacement with some of our immigrant population. These are all different things and all different categories which our children are being impacted. And so think about it. If I already have some mental health concerns that are underlying, undiagnosed, and maybe I'm also on the spectrum for some things, and then you add all this, how potentially am I functioning within that space? How am I functioning? How am I able to navigate? And really, for some people who cannot communicate, how might this display? How might this display? And I'll briefly go into social determinants of health, which I kind of went over. But what that looks like is, say I need help, say I want that support, but I'm living in an environment that is influencing how I am able to respond and how I'm able to cope. Meaning healthcare access and quality are not available. Education, I'm in some of the poorest neighborhoods, so the school systems are not giving me that support that I need. We barely have textbooks, or we barely have qualified teachers who are teaching us and growing with us and are culturally and linguistically competent. to handle some of these neighborhoods and some of these spaces. Again, social community context. Maybe there's not safety within my space, or food deserts, things that we talk about, economic stability, neighborhood and built community. All of these things can factor into how we deal with children and how children function. Again, they're carrying so much. They're carrying all these different facets, and they're not getting support because it's not available. It's not accessible. This is going to impact how they function throughout. And that's really how we hit that social determinants of health. And those are something that we really got to layer on. I tell my students all the time, when you are doing evaluations, it's not just about what's going on in the person. We've got to look outward. We got to look into that environment. We got to look into their families. We got to look into, their financial stability of that family, because we may offer things, but they're not accessible to them. And also, when they are accessible, they may not be as quality. These are things that may not be adequate enough to give them that support. And what happens with those dropout rates, if we go in and we're not feeling it, or we're feeling like people aren't there for us, you know what? No, thank you. And in my time when I work with kids, trust is that major component to being able to get them the support that they need. And if they don't trust you, or they feel like you're not there, or you don't have shared experiences, then you'll be looking at a caseload that has high turnover, with kids that just do not want to engage, and families that do not trust in a system that is designed allegedly to help them. And again, that's a whole different conversation I can go into as well. So within our treatment systems, we got to go there. And if I'm going too fast, I can slow down, but I really want to kind of leave some space for questions too. Some of the challenges that we see are with our minoritized youth. As I mentioned before, that ODD diagnosis, Black and Indigenous individuals are more likely to be misdiagnosed or criminalized. Again, that deficit-based thinking. Instead of looking at what is right with the person, we're quick to look at what is wrong. How they're presenting what is wrong, and as if it's their fault and they are to blame for some of the consequences, some of the things that they're dealing with within their spaces, right? They're being misdiagnosed. Additionally, LGBTQ plus neurodivergent people face compounding stress and discrimination. And I'll get to some numbers in a second. But we're adding components, we're doing those intersectionalities, we're looking at all of the different things that define a person. Each is carrying its own weighted amount of stress, which is compounding stress, compounding issues, compounding these concerns. And if you're not getting the support that you're needed, depression, anxiety, all those things can be high as well. We talked about it through social determinants of health. Low-income individuals may lack access to diagnosis or treatment, or even proper. Let me put that in there too. Again, limited linguistic or culturally appropriate providers. So that's just not essentially knowing how to deal with Black or brown people. But what that really is, do you know the language? We do a lot with language. We do a lot with linguistics, right? Do you understand that? Or do you demean or look at them as a deficit-based process because they're not speaking the way that you do? And even if a person is not, English is not the first language, are we prepared to handle that? Do we give them materials that are in other languages? Do we give them things, or maybe they have some vision impairment there too, or hearing impairment? Are we being appropriate within those spaces? Providers, left hand don't know what the right hand doing. And I've experienced that too many times. Have no clue what is going on. And we have this person in the middle that needs the support, but you have providers with competing interests. One's pushing meds, one's trying to push this, the other one doesn't know what the other one's doing, and before we know it, we have this person who is not getting the support that they need. Family support or understanding. I deal with a lot of families, and when their children are diagnosed, say they're on the spectrum, for example, there's a lot of denial and a lot of shame and a lot of blame that goes on there too. Well, my son isn't, on the spectrum. I don't know what you're talking about. He just doesn't listen. Or, then they blame, well, that's on his dad or his mom's side. We didn't have those problems. There's always that blame. What do you think that does to that child who is functioning differently? And they think their thought is unique, but the family doesn't understand. And sometimes it is due to lack of plain ignorance, or ignorance in a sense where they've never learned it. Nobody ever took the time to teach them and to really truly invest in their education and their ability to help that child too. If you think about these providers who are misdiagnosing, sometimes we listen to the provider, or the provider say they don't have it, so then they don't. And then you go to the school, and the school is saying school counselors are working with them, or school psychologists are working with the students. And there's a lot of misinformation. Again, left hand don't know what the right hand's doing, and that child's in the middle. But one of the biggest issues I see when we're working with our students that are diagnosed with neurodivergency is that stigma and that shame. And that's from the parents, and that's from the family members. Or there's jokes, and there's bullying, and there's different things that occur. But how are we truly supporting and investing in someone who is different than us? How are we truly, truly doing that? In the bridge here that we look at, 70% approximately of youth diagnosed with autism suffer from at least one co-occurring mental health condition, which can be exacerbated or triggered by or in conjunction with the autism spectrum or any of the other neurodivergent that we'll look at. Anxiety for maybe being misunderstood or unclear, or just having that panic when I'm around people or I'm not socializing well, or to the standard, so to speak. Suicidal ideation affects 25 to 34% of youth with intellectual disabilities. And then our lifetime rate currently is at really about 10%. Self-injurious behaviors are higher. Depends on the functioning, but some that do some of the repetitive head banging or even just other acts of harm towards themselves out of frustration because they don't understand and they can't really verbalize some of the nonverbals. They're higher than non-autistic individuals. And then the biggest thing we see is there are limitations with clinicians who are specialized to deal. Again, my training, we didn't have it. You get approximately 16 weeks to learn all of the big DSM, and then you got to go figure it out. And if it doesn't run across your desk or it doesn't run across your space, then 9 times out of 10, we're probably not going to learn it. And we do have professional education, and we're supposed to now, per ACA, follow those mandates and stay abreast of what's new. But a lot of us do not. We're old, we're tired, we're doing everything else, we're juggling so many hats that when someone comes across our desk, our first thing is, well, I'm going to send you to a specialist because I don't deal with it. Instead of really trying to learn, really trying to navigate, really trying to focus, it's again that blame and that shove off of, well, somebody else can do it because I don't deal with it. Think about those layers, think about those intersections, think about those things that I've mentioned. These are all key to functioning and all key to helping and building that bridge that I'm telling you about. Now, I borrowed this from our wonderful board here. But what we need is in essentially bridging the gap, closing the wall, breaking down those barriers. We need all these facets talking to one another. We need all these spaces communicating and working together to address these mental health concerns for our students. Education, the teachers, the faculty, staff even, they all need to be abreast and trained with how to deal with certain things. Social service entities, healthcare, all these really truly go together to support that family and that person that's in the middle. As I mentioned before, everybody's in their own space, which is, I know it's the theme of our conference, but everybody's doing their own thing. Not really communicating what is going on and how we can best support that student and that family. And there are some wraparound services. I'm not going to sit here and say that they're not. But what I will say is that they can be improved. And we can work together, again, co-conspiring, because we are all invested in this space. We're all invested to help. We're all invested to engage. So some of the treatment modalities, just to give you a brief rundown here. CBT, cognitive behavioral therapy. Okay. If we change how we feel, we change the way we act, we change the way we think, or think, feel, act, think, feel, however way you look at it, right? We're trying to change, ultimately, the thoughts and the behaviors and improve emotional regulation and coping skills. How do I relate? How do I do some of these things? DBT, again, emotional regulation and stress tolerance. So working with individuals in distress tolerance so that when they are getting frustrated or they are getting, exhibiting certain signs, they can learn how to best regulate and remain mindful when they are being triggered. Occupational therapy, social skills groups. Something else that really needs to be ingrained there is play group, expressive arts therapy, really meeting people where they are and helping them build towards where it is that they want to go. But a lot of times what happens is these modalities, they are fixed in these white hegemonic thought. and not considering cultural component, as I mentioned before. And there are a lot of, there's some other modalities that are not up here, but just giving you the basics of, we need to be creative. This is something that is unique to our field, and it is something that should be treated as uniquely as it is. So it requires us to think outside that box. Again, build that bridge and work on how can we all work together for the common good. And with me being a clinician, maybe I don't know these things, but guess what? I'm going to learn them. Not going to just pass the buck, or not going to just say, well, I don't deal with that. Because that person I'm saying I don't deal with, eventually that's going to be that adult in my office that's saying, well, nobody wanted to help me then. Too many times in our role, I'm trying to fix people, because again, that deficit-based thinking, we fix because something is wrong. That automatically asserts a blame game there. What we need to be doing is looking for improved understanding. We are not looking for problems, and I don't want to go too solution focused, but what are the solutions? Let me meet them where they are, and how can I best get them to a level of functioning that's appropriate for them, and also meeting the goals that they want to meet. In mental health, we have to be more affirming. Recognizing communication differences. I'm saying differences, not deficits, differences. We are all different. We are all unique, so we need to be treated as such. Sensory needs are key. For example, someone that may be more triggered to sound or light, you have to be more amenable to these conditions. Is my office appropriate? Is this space appropriate for this person? School can be a lot. These areas can be a lot. Are we continuing to send them to these places and in these schools? And a lot of times what happens too, these children are placed in a special ed because we don't understand, which is more triggering than we even know. That's, again, a whole different conversation for a different day. But there is such a need to support families that may have a child that's been diagnosed or is dealing with this to a degree. Because a lot of times the families is the structure that's the support. And then the other thing I would say here is you got to be aware of how are these families composed and how are these families constructed. One of the things that I've looked at is I have a lot of grandparents raising kids that are on the spectrum. And grandma, her patience is very, very short. So she does not understand that Junior is twirling and Junior can't get back on track right now. All she sees is Junior's hard-headed and I need to get the belt for Junior. And I'm being honest with y'all. This is what we see. So these kids, again, are being chastised because they're unique, because they're different. They don't process in the way that which we do. In the same way I'm telling you all that I didn't learn it, we hear it all the time. We didn't have this when I was growing up. Just because we didn't have it doesn't mean that we don't have to learn how to handle and understand and deal with it. We need peer support and community-led initiatives like this conference here. I hate that I can't be with you all in person. This is amazing. This is an amazing space to gather and gain support to be able to help individuals in need. The increase in the number of providers trained in ASD and offering more dedicated programs. Even when I want to refer out, I really can't because there's not any qualified or adequate spaces to refer to. So while I may want to do it, I don't know anywhere that does it. And then they have specialized schools and they do have different things like that. But, you got to think about functioning levels and when we're diagnosing too. You have some high functioning cases that are not being treated. They're being treated the same as some of the lower functioning because, again, we don't understand, we don't know. And that creates barriers for those students and barriers for those families that did not have to be there if we had just taken some time and gotten the education to understand and given that person the support that they need. So, there's something new that's floating around. And again, this is a newer area, right? But neurodiversity affirming therapy. That is a celebration of the unique strengths and perspectives rather than looking at, again, what is wrong? Why are they non-normative behaviors? Why aren't they following our perspective because we're all one world? No, but it's celebrating and appreciating those unique strengths and then building upon those things to help that person function in a better space. Self-acceptance. Before we were being bullied and we're being shamed, we can now work towards owning the things about me that are unique. The things about me that make me special. And on the same line, we have to be able to account for the co-occurring mental health or medical concerns, because you can't, like I say in substance use, I can't really treat the substance use without addressing the mental health and vice versa. So here, I cannot really treat, the anxiety if I don't first deal with the autism, that person that's on that spectrum, or that person that has ADHD, or that person that has, depression. We have to be able to not only account, but understand. And maybe I'm not an expert, but that comes in where I'm building my bridge. I'm building my bridge. I'm working together for the betterment of my client and that person. So, for example, having regular strategy sessions with teachers that deal with it. Because, if you think about it, in schools, our kids spend majority of their time in school. So who's with them monitoring? Who's with them watching? Who's with them observing? The teachers. But the teachers have, 20 plus, 30 plus, some schools to deal with. But how can we make more intentional efforts? And again, systemic barriers are more difficult to address, but what are some things that I can do? And when I was a clinician in the field, I would make it my best. I would call the teachers. I would talk to the teachers. I would go to the school. And sometimes they didn't want to talk to me, but I'm there. Having a conversation with the doctors, seeing what we're seeing, is this person on a developmental path, so to speak? Are there any co-occurring concerns? So it means we're going outside of ourselves. We're doing more. We're building that bridge to success for that person because I'm willing to do the work. I'm not just going to sit on my hands and wait for somebody else to do it. I'm going to do it myself. Because at the end of the day, I want this person to reach optimal functioning. I want them to feel good about themselves. And also what I'm doing is modeling, because I'm teaching them how to model and how to advocate for their needs. If I'm not just going to keep going to a provider who is not clicking, who is not understanding my culture, who is not understanding my unique space and my unique needs, who keeps going from it from a deficit space. These are things I'm not going to do. So coming outside of our own boxes, again, reaching across those lanes, building those bridges, and being able to say, I want to do more and I'm going to do more. Because as we continue to evolve, we have to evolve as people and we have to evolve as clinicians and we have to evolve in whatever space that you may be in. There has to be an involvement. I went a little quicker than what I wanted to, but any questions or comments or anything? I think I could field a couple. I don't even know how much time I have here, but definitely appreciate you all for listening and providing me this space to be able to talk to you this morning.